Hello and welcome back to my podcast. Today I have a guest, Nicole. She's a pelvic floor physio, and I just wanted to introduce her, and maybe Nicole, you can share a bit about what is a pelvic floor physio, because I know a lot of people are confused, and like who would come see you, and maybe like why you got into it.
Sure. So a pelvic floor physio is just like a regular physio. So we do all the same training. But after you graduate, you do additional training in terms of pelvic floor and core health. So someone would come to see a pelvic floor physio if they wanted to deal with any type of incontinence. So that's leaking with laughing, coughing, sneezing, running, jumping, often known as mommy bladder because it's normalized, but that's something that we would want to come to physio for. We would want to see somebody if they were dealing with what we call an overactive bladder. So that's that feeling like you have a small bladder or you're going to the washroom more than people around you. You feel like as soon as you have the urge, you just need to go because you feel like you can't hold it, those sorts of things. We would want to see somebody if they were dealing with prolapse. So that's any kind of heaviness or pressure with often with like being on your feet all day or like lifting, those kinds of things. Any fecal incontinence. So that's any stool that's coming out when you don't want it to be coming out. And then anything to do with the core. So a lot of times people are coming in because they're concerned about diastasis in pregnancy or in postpartum. And a diastasis is a stretching of the tissue in your core. And we're chatting with people about core rehabilitation.
Whoa, that's so cool. I already have a million questions, but so tell me a bit about like what brought you into that, because like that's very specific and honest work that you do. So I'd love to like learn about like what got you into being a pelvic floor physio.
I think so. Initially, what got me into being a pelvic floor physio, and it's not what I thought I would be doing going into physio school. I didn't even know that it was a thing.
Yeah.
And so, yeah, I went through training I started physio in 2015 is when I started the master's. Then I graduated in 2017 and I did my pelvic floor training, or I started it in 2018. So pretty quickly after. And honestly, it was, I think growing up and, you know, I'm from an Indian background and there's a lot of like gender inequities and things like that. And, learning a little bit more about some of the things that, you know, people with female anatomy face in terms of childbirth, postpartum, and then of course people who've never gone through childbirth or postpartum, but dealing with things like pelvic pain with intercourse, all of that sort of stuff, which just sort of gets brushed under the rug. It's not really talked about. It's not really dealt with. It, again, like I was saying earlier, it's just sort of normalized. So it was just my kind of small way of feeling like I was doing something to help women essentially deal with their own health and feel more empowered and all of that. So that's what initially kind of sparked the interest. And then what kind of propelled it a little bit further was I dealt with a ovarian torsion. So essentially,
I've never heard of that.
Yeah, what that is mine was caused from, I had these like very large kind of benign dermoid cysts or tumors on my ovaries. You can Google that, but don't if you're squeamish because they have like teeth and hair and it's just like really freaky.
I've heard about the teeth thing. Okay.
Yeah. So I had two of those. I didn't know it. And then I was working one day like as a physio and it just torsioned and it went undiagnosed for a little bit. And so I was just kind of dismissed as like being gas pain and these kinds of things. And I mean, if you know anything about a torsion, it's technically an emergency surgery because you can have a lot of complications and really bad outcomes if it's not diagnosed. Luckily, that didn't happen for me. But anyways, kind of going through that experience and then going through some fertility preservation stuff with like IVF and things like that just made my passion for the area a lot stronger. So.
Wow. Did you have that when you're a physiotherapist? Mm-hmm. So you went through it. Yeah.
Yeah. So I graduated in 2017. I started pelvic floor training in 2018. And then this happened later in 2018. So then, yeah.
Did you see a pelvic floor physio for those issues that you're having, or did you find like there was not much available?
Yeah, no, I didn't. I think just because I had a bit of a background in it anyway, so I was able to sort of like self-manage. And I wasn't dealing with anything like major other than like a bit of pelvic pain, I guess. But yeah.
Okay.
No, yeah.
Well, that's really cool. I had no idea. I mean, oftentimes when you get into some like careers that are a little bit more niche, oftentimes it comes from like a really strong why. So I really I appreciate you sharing that.
Yeah.
Awesome. Thank you. All right. So one of my first questions, and a big fear I get commonly for clients, and even as my own personal self, is tearing. How can somebody prevent tearing when like giving birth? And are there some positions that help reduce tearing, or can kind of help the baby ease out so that there's like less risk? And like, what are your general thoughts on tearing? Like, is it that bad to tear?
Yeah. I hear that a lot as well, and I'll have people come in with that specific question. So usually what I'll kind of start the conversation with is because, people are afraid of tearing because they're afraid of pain during labor or during delivery, and they're worried about pelvic floor dysfunction and pain postpartum. And so when we're thinking about pelvic floor health in general and pelvic floor dysfunction, we want to be thinking about all of the things that contribute to that. So it's not just this one singular event in delivery that is going to kind of be a make it or break it for your pelvic floor. So kind of just looking at it more from this big picture, there's all sorts of different lifestyle factors that play into your pelvic floor health in general outside of pregnancy. So then when we're talking about actually like in delivery, thinking about tearing, so there's different grades of tears, right? Grade 1, grade 2, grade 3, grade 4. And we kind of lump them as grade 1, grade 2 as minor, grade 3, grade 4 as more severe. Grade 1, grade 2, the more minor tears are very, very common, to the point where it's almost like, should this just be sort of expected to happen to a certain extent? So really what we're more concerned about trying to prevent or, to try to prevent would be the more severe tears, the 3 or 4. Third or fourth degree tears. And so that is less common, and about 5% of people will experience that. And so, that's kind of an overarching way to think about it. But other than that, there's various factors that influence tearing. So usually when I'm chatting with clients about it, we're talking about maternal factors, fetal factors, and then during delivery. So what are some factors within that delivery that can influence tearing? And then what are some potential things that we might be able to do that may have a positive impact in terms of reducing some of the risk? So things like maternal factors would be, age, whether this is your first time giving birth, how long or short is your perineum, so different anatomical factors can play into it. Okay. Fetal factors would be like baby size, does baby's shoulder get stuck on the way out, what's the size of baby's head, those kinds of things. And so, all of that is pretty uncontrollable, right? It just kind of is what it is, and so there's not a whole lot that we can do about that. When we're thinking about things in terms of like what's actually happening in the delivery, it's a little mixed in terms of what can be helpful or not helpful. And so there is some data to show that using like a warm compress on the perineum can be helpful in reducing severe tears. That's that 3rd or 4th degree tear.
Which I do see most nurses, if not all births I've been to, they do that, which is amazing.
Yeah, absolutely. And so usually what I'll advise people to do, because I'm not in the birthing world, so I'm not there when these things are happening, but it's just like, these are conversations that are best had with the people who are actually going to be at your delivery. So chatting with your doula if you have one, chatting with your maternity provider, and just kind of seeing what practices they use on a regular basis.
Cool.
What they're comfortable with. But and then there's conversations around like birthing positions, and so does that have an influence on tearing? And again, wanting to keep in mind like all of the other factors that we talked about. So yes, we can talk about birthing positions and their impact potentially, but it's if we're talking from like a research standpoint, it's pretty hard to study this stuff when there's so many factors that are influencing it, right? So it's
so true.
When we're thinking about trying to compare one thing to another, you have to kind of control for all of those other things. But if you can't really control for all those other things, because it's just too hard. So
totally.
So when we're thinking about birthing positions, what I'll say is, and I think Sydney, you have the same sort of viewpoint, that whatever birthing position feels best for the birthing person is number one. So that we want to be thinking about that at all times. The other thing that we want to consider from a pelvic floor standpoint is what position is the sacrum in? And so the sacrum...
I was going to say, just in case are you going to explain what the sacrum is?
Yeah.
As I cut you off.
Yeah, I wish I could demo with my pelvic model. That's how I usually do it. But if you're thinking about where your pelvis is, if you imagine where your hips are in your body, right? That's the side of the pelvis. Then you've got the front of the pelvis where that pubic bone is, right above the labia. And then the back, if you imagine where the low back is, right below that is your sacrum. So it's a triangle bone that's sitting
the tailbone, as like a layman's term would call it.
just above the tailbone.
Just it's above the tailbone. Yeah. Cool.
Yeah. So, and then the tailbone's like right at the base of that, and then
Cool.
the pelvic floor connects right into there. So when we're thinking about pushing, we want to keep in mind that that sacrum and tailbone actually move. So if it's in a non-fixed position, which just means that you're not laying on your back essentially. So if you are, for example, in an upright position, or if you're 4-point kneeling or even side lying, that sacrum will be able to move about 16 degrees backwards. And so the reason that's important is because when it moves back, it creates a little bit more space within that pelvic bowl, which creates more space for baby to come out and through. Now, that being said, when you are laying on your back, right, and if you're just flat on your back, there is about 4 degrees of movement that happens there. So it's quite a bit less than if it's in a free position, which is what we call it. So if you are laying on your back, and I really want to make this like clear as well, that being on your back is not the worst thing in the world. Like, some people are more comfortable on their back for various reasons. If you have an epidural, I mean, it's not to say that you can't try being on your side or even 4-point kneeling, depending on how comfortable you are. But if you are on your back and that's what feels best for you, that's okay. What you can do is you can roll up to bath towels. If you imagine 2 bath towels rolled up, and if you place them underneath each butt cheek, basically. And what that does is it creates a little bit of a gap between where your sacrum would be, so where that low back is and where the bed is. And so then
cool.
You have a little bit more space there.
Such an easy little fix to do that like someone would not even notice, and probably would feel a little bit more comfortable having that. You know, going back to the sacrum, I actually went to a birth where the sacrum clicked and moved. So the whole room paused, and we were like, what was that? And the midwife and I look at each other, and we have the client picture her on all fours, and I'm on one side of the hip and the midwife say the other, and I'm rubbing her sacrum, I'm rubbing her low back, and all of a sudden we hear, and the sacrum was the highest sacrum I've ever seen. It was like, it looked like a hump. And then whether the click was the sacrum or whether it was the baby going under the pelvis, we don't know. But me just rubbing that sacral area, the baby, we went from, okay, maybe the baby will be here in about 4 hours, to the baby was out in 3 minutes. So it was crazy. And I wanted to get a photo, so then it was like, grab a camera, or grab it. And it was like, oh my God, it happened so quick. So that was really cool to see it in person. Yeah. Sometimes you don't get to see that sacral movement, but for her it was super prominent. So yeah,
and I do
really
wonder
epic.
how much an impact massage had on that, right?
That's what I said. I said it was that massage technique I did.
Yeah, exactly.
Everyone's joking that it was definitely the massage technique. So
magical hands.
Totally.
Yeah.
And then one other question, going back to it, not that I want to like spook anyone out, but I just was curious more about like the 3rd degree and 4th degree tearing. Like, is that when you're talking about the tear going into the perineum towards the anus, or is that what's considered a 3rd and 4th, or maybe you can kind of explain the difference between 2 and 3.
So with a 3rd and 4th degree tear, it's the 3rd degree is going further into that, so further back through the perineum, so towards the anus and deeper into the muscle, so deeper into those pelvic floor muscles. And with the 4th degree tear, it actually goes through the anal mucosa.
Okay.
So that's the difference between a 1st and 2nd. So 1st degree tear, sometimes you don't even need stitches for that. It's just like a little bit through the mucosa of the vaginal the vaginal wall. And 2nd degree tear would require usually a couple of stitches. Okay. Yeah.
Would somebody with a 2nd degree tear expect to book in for a physio, or do you feel like they heal beautifully on their own? Like, what's your... One would obviously somebody would come see you with a 3rd degree tear, but would you say like a 2nd degree tear would warrant somebody booking a physio appointment?
Yeah, I would anyways. I mean, I would recommend pelvic floor physio for anybody postpartum, whether they have a C-section or a vaginal delivery with no tears all the way through to a 4th degree tear.
Amen.
And the reason for that is when we imagine somebody, right, if they've gone through like a knee surgery or an ankle surgery, right, if they broke their ankle or had a knee replacement, there is physio with a knee replacement that same day. They're seeing somebody right after their surgery in the hospital, and that's because it promotes a better outcome in terms of rehab. And if you had an injury anywhere else, kind of like orthopedically throughout the body, shoulder, hip, knee, anything like that, it wouldn't be kind of unheard of for you to be like, oh, you should, think about some rehab for that, regardless of whether it's a sprain, an ankle sprain, or all the way up to like a broken ankle that's had surgery on it. So
true. Oh my God, I didn't even think about it that way.
Yeah, and it's like very common to like not always put it in that same context, but when we think about a vaginal delivery, if you imagine somebody who has a 2nd degree tear, they may not have, the same objective differences in terms of how much tear has happened, but it doesn't necessarily mean that they don't have other things going on. So for example, it's hard to say. Everybody looks a little different, so I can't really say for sure, right, what somebody would look like with a 2nd degree tear, but it's there's still all sorts of things that can be going on there. Somebody could feel totally fine initially, and then maybe they try to, at the 6-week mark, they feel like they're more comfortable. And I'm not saying that you have to wait for 6 weeks to do any movement, but that's typically what people are imagining, is that they wait for that time, and then now they can return to exercise, or they can try to have intercourse, like vaginal penetrative intercourse, things like that, and they go to try some of those things, and they're like, oh wait, this actually doesn't feel very good, or it's painful to have any type of penetration, or now I'm exercising and I'm noticing that I'm experiencing some leaking or heaviness, pressure, those kinds of things. So it might not be as obvious at first, but it can certainly start to pop up.
So true. On. Do people have to wait 6 weeks to see a pelvic floor physio as well?
No.
So okay.
And
fake news. I was telling people 6 weeks, and my apologies.
No.
I thought it was. So.
It's really common for people to think 6 weeks, and that comes more from the idea that if we're thinking, a lot of times people are equating pelvic floor physio with like an internal assessment. And you don't ever have to have an internal assessment when you come to pelvic floor physio. It can certainly be a part of it, and we can gather a lot of good information from it, but that's, I think, where some of that 6 week kind of mindset comes from. Like, we want to make sure that you've seen your maternity provider, and that the incision or any kind of any type of incision has been healed fully before someone's kind of like doing an internal assessment on you. But you can see a pelvic floor physio at any point postpartum. So it could be, a week postpartum, or it could be 2 weeks, 3 weeks, anything like that. And the reason for that would be, again, coming back to that idea of like supporting the rehabilitation process throughout the whole time. So rehab is starting, immediately postpartum. So, baby comes out, the rehab process is already starting at that point. And so we can be providing education before that happens. So actually in your pregnancy and throughout that process about how you can better support your healing. And those appointments can be virtual, they can be in person. We would never be doing any type of internal assessment until the tissue has fully healed. So until that 6 week mark. And again, at that point, it's your choice, and that would be a discussion that you'd have with your physio. But
Well, that's so cool. Thank you for explaining that. I think that like having more resources and continuity of care is so important. I think that's like really awesome that I think the pelvic floor industry is like changing how people even approach birth now, which is really cool. So I appreciate everything you do. I think the next subject I want to touch on is forceps and vacuum deliveries, and what are your general thoughts on them for people who have never given birth or don't know what they are, maybe explaining what forceps and vacuum are and how they relate to the pelvic floor. And maybe you could just share some like thoughts and feelings on that.
Yeah, for sure. So I'll start off with, I guess, just explaining in case anyone's not familiar, but the pelvic floor muscles are a group of muscles that sit at the base of your body. So right between your legs, in between the pubic bone and the tailbone. So imagining a group of muscles that sits there, and they're involved in birth in that the uterus is where baby is, and it's the muscle that's contracting and bringing baby down and through the birthing canal. And the pelvic floor muscles, what we want them to do in birth is to basically open up and move out of the way to create space for that baby to come out and through. So then when we're thinking about vacuum and forceps, so a vacuum is like a little kind of cone shaped thing that sits on the top of baby's head, and then they pump. I don't know how to describe it more than that, but they basically just use this little pump, and it kind of helps to draw baby out and through the birthing canal. And a forceps kind of looks like tongs, essentially, like they're bringing the forceps into that vaginal canal, putting it along baby's head, and then using that as a way to help baby come out and through. And so the reason that is part of the conversation around pelvic floor health is just because, again, if we're thinking about where those pelvic floor muscles are, sometimes when we are using things like a vacuum or a forceps, pelvic floor muscles can be impacted. Now, the degree to which pelvic floor muscles are impacted, like that's sort of hard to say. Again, going back to what we were chatting about earlier, like there's so many other factors that come into this. Sometimes when a forceps is needed, they do have to do a bit of an episiotomy, so like an intentional cut, so that they are able to get the forceps into the vaginal canal. And again, that's just a decision that the OB is making at the time. And so they're kind of making their best judgment there. And so if that's occurring, right, so that's going to be a tear that's coming into the pelvic floor muscles, and we're wanting to think about that when we're thinking about rehab and postpartum. And it's, again, I think previously it was thinking about forceps and, for sure there's going to be pelvic floor muscle dysfunction if there's forceps used, but I don't think we can make that kind of like overarching statement. It also depends on all the other factors, like I was saying. So if we're imagining a birth where, for some reason baby needs to come out a little bit quicker, and perhaps baby isn't actually as far down that birthing canal, and for the safety of mom and baby, we just kind of need to get baby out. So forceps is used a little bit higher. That might have a different impact on your pelvic floor versus if baby's just kind of right at the entrance there and they just need to use a little bit of an extra pull to get baby out and through. So it might be a little bit less trauma on the pelvic floor. There's concern sometimes around tearing, for sure, which we already chatted about. And then also, what does that look like afterwards in postpartum? So things like incontinence and pelvic organ prolapse are often things that are people are feeling worried about in postpartum. And so a little bit of mixed data on whether forceps is actually linked to an increased risk of pelvic organ prolapse, where I think previously it was thought that for sure it is linked, but it's a little bit more murky. Yeah. Okay. So I'm saying all of that just so that, again, it's understanding what these devices are, and definitely chatting with your birth providers around like why might they be used, so that you're understanding, if you're in your birth and your providers are suggesting that they an intervention would be helpful for the health of yourself and for your baby. Having some understanding beforehand about like what is that, what are the risks of it, and then what are the alternatives. So if you're not wanting to use a forceps, then what are the other options? Is the other option a C-section? And then what are the pros and cons of a C-section? And that's going to look a little bit different for everybody. And part of that is, again, because there's risks involved with a C-section as well. So if this is your first time and you only want one baby, then maybe you're okay going that route, versus maybe you want 3 babies, and
that route being
the C-section route. Yeah, exactly. Versus if you're wanting more pregnancies, it's not to say that you can't do that. It's just understanding that, if you've had one C-section, there's scar tissue within that uterus. And then when you get pregnant again, there can potentially be some risks with that. So really just being mindful about having these conversations ahead of time, so that when you're in the moment, you feel comfortable and confident with the decisions that are being made.
For sure. I think that it's like going back to how birth is obviously a very sacred and spiritual experience, but on the other hand, it's also a medical event. And so like understanding like what are the risks, what are the benefits. I think I might have mentioned this in another podcast, but using like the BRAIN acronym. So B being what are my benefits, R being what are the risks, A what are my alternatives, I what does my intuition say, and then N is what if we do nothing. And I think that's, even if you can remember maybe 2 or 3 of those, that could go a long way in birth. But I think one of the biggest takeaways I took from just hearing what you were saying about the forceps and the vacuum is something that you could do in your birth to be more empowered is ask how high up your baby is. That might not be something that you would otherwise ask or even know about, and that may change your decision. And what is your health history? Is this your first baby or is this your last baby? Okay, well, maybe that might change. Maybe a C-section might be the better option for you if the baby's higher up. But ultimately, like if the forceps or a vacuum is being introduced, it's always for the best intention of you or the baby, right? But you have to weigh out, like, there's also you are also a patient, and so is your pelvic floor. So you have to make sure that that you're okay with some of those risks involved. I know, like, going on the risk too, there's also some risks in terms of baby, depending on how high up, and it could cause damage and harm to the baby. So that's also something that you should talk to your care provider about. And I'm not saying this to scare anyone, but I do think that if you're listening to this, having the knowledge about it prior to, so that if these are introduced, which forceps aren't as common nowadays, I find, but vacuum for sure, it's good to understand and know about it so that there's no surprises other than the baby's gender at birth. So so yeah, that's really cool. Thank you for, like, sharing on that. I feel like I learned quite a bit just asking you those couple questions. All right. I wanted to also chat about pushing. I remember my first birth, I went into it and I was trying to coach my client on breathing your baby out, and she had an epidural and it was her first baby, and I got yelled at right away from one of the nurses being like, no, that's not going to work. And it was the first time I realized, like, in doula school, we learn about relaxation techniques to get your baby out versus bearing down and pushing. And I didn't realize there's an entire other category of coach pushing and when that's helpful and beneficial versus breathing your baby out and when that's helpful and beneficial. So I actually now, when I teach it, I have like a chart, and I have like instinctual, natural breathing your baby out portion, and then coach pushing, and where would you use both and what kind of breathing techniques. I still feel like I could probably touch up my knowledge on that, and I know that you have a lot of education around that, so I'd love to hear more about those types of pushing techniques.
I mean, I'm also curious to hear your perspective as well, like you said, because you're actually there in the birth. So, you know, I totally agree with what you were saying. We can read and learn about something, and then when you're actually in the moment and experiencing it in real life, then things can look a little different sometimes, a little different than we might expect. So, so the way I'll chat about it with people is that, again, similar to pushing positions, pushing baby out, it's birther's choice. So, you know, if you want to just kind of go with your instinctual, what feels right for you in terms of how you want to push in that moment, go with that. And if it's helpful for you to listen to somebody, whether that's your doula or the nurse or whoever's there, then you can go with that, right? So just kind of do whatever feels right in that way. When we're talking about pushing, we talk about it like an open glottis push or a closed glottis push. And all that means is that, are you breathing as you're pushing, or are you holding your breath? So open glottis is that you're inhaling and you're exhaling as you're pushing, and closed glottis is where you're inhaling and then you hold your breath as you bear down and push out.
So do you bear down with the open glottis? So as you're breathing out, I guess, do you bear down as well with that?
Yeah, exactly. So basically when I'm teaching this to clients, it's sort of like a stepwise thing. We're first educating on like where the pelvic floor is and what those muscles have to do with birth. And then we're talking about, okay, so when we're thinking about pelvic floor muscles, they contract, and that's a lot of times what people are familiar with, right? That's a Kegel. But then they also do the opposite. So I explain it like an elevator in a condo. When you're at ground level, that's your pelvic floor just hanging out at resting tone. So there's a little bit of tone, but not too much. When you contract, it goes up level 1, 2, 3, 4, 5. So it's maximal contraction. It can come back down. When we're thinking about pushing baby out or having a bowel movement, we actually want those pelvic floor muscles to go down into the parking garage. So imagining those pelvic floor muscles are actually lengthening and opening up. And so that's part of it. And the other part of it is directing the pushing. So a lot of times, I shouldn't say a lot of times, sometimes people will assume that, oh, okay, I'm just going to push, right? that pressure is going to go down where it needs to go. But that's not always what happens. Sometimes when people are pushing, they're actually pushing through their abdomen or through their legs. And really what we want to do is teach people how to direct their bear down or their push through to basically their bum.
Okay.
So when I'm teaching people on how to do it, it's that idea of first connecting with your pelvic floor and understanding what does it feel like to actually have an open, lengthened pelvic floor. And a lot of the ways that we're doing that is through feedback. So whether that's touch, so I'm actually internal touching those pelvic floor muscles and the person's able to feel, oh, I actually feel that pelvic floor opening up. Or if we're not doing an internal, then we're using other things like they're sitting on a rolled towel or something like that and understanding what it feels like to open up their pelvic floor. And then what we're doing is, so we're inhaling, breathing down into your pelvic floor. So sometimes one of the cues that I'll use is if you imagine a rose that's closed and it's sitting at the opening of your vaginal canal, so it hasn't bloomed yet. When you're inhaling, so you're breathing through the diaphragm, the big muscle underneath your lungs, between your ribs, the diaphragm comes down as you inhale, so pressure comes down, pelvic floor relaxes with an inhale. So you're imagining that flower is blooming open, and then when you exhale, you actually want to keep that pressure down versus what normally would happen in everyday life is you exhale and the pelvic floor just contracts back up and air goes out. So you can try this right now if you place your hand on your low belly.
Okay.
And you breathe through your diaphragm. So breathing in, you want to think about that air going all the way down into your pelvis, imagining like it's coming down into the vaginal canal or the anus. You should feel that your low belly expands a little bit into your hand as you inhale if you're doing it properly. And again, not everybody does. Sometimes people will breathe and they're actually breathing up into their chest.
I'm still breathing in my chest.
I know, I noticed that. That's why I said
it. Oh, no.
And it depends too, like a lot of times we're wearing jeans or pants or things like that restrict our abdomen from actually doing that.
It's the opposite with the pelvic floor. I realized when you relax, the pelvic floor is contracting, and then when you exhale, it's... Oh wait, maybe I messed it up.
Yeah.
I don't know.
So imagining inhale, diaphragm comes down, pelvic floor comes down. So pelvic floor is relaxing on the inhale, and a lot of times that's like a confusing thing.
That's what I mean. Yeah, it's the opposite of what you would usually think.
Exactly. Yeah.
And then when you exhale, the pelvic floor comes up. Yeah. It contracts. That's okay, because I do these techniques for my pelvic floor randomly, but I have to like actually like think about it.
Yeah, I know. People will come in and they'll be like, it's like a mind twister, and it's like mental work, and it really is like to connect with this area. So, as I was saying, you're breathing in, you should feel your low belly expand, but then just passively let that exhale out. What will happen is your low belly just kind of comes back in. When we're thinking about pushing, what we want is inhale, low belly expands. Exhale, you want to keep your low belly expanded. So it feels like a more of a forceful exhale because you're trying to keep that pressure down. And that's sort of starting to learn the idea of like, oh, we're keeping our pressure down in our pelvis as we're exhaling as a way to push. So I'll teach that, which is that open glottis push, but then I'll also talk about closed glottis pushing, which is inhale, low belly expands. It's the same thing. And then we hold our breath and bear down and keep that pressure down. And the reason I teach both is, again, because when we're thinking about birth, I do think that a mixed approach works well. And I think that that's probably a little bit more realistic in terms of what people are actually doing in their births. And so, again, it's coming back to that idea of like pushing positions, like don't push on your back. Like we don't want to demonize different ways of like pushing or different positions because again there's so many factors that play into some of these things and why somebody might need to push a certain way. So
totally.
I
think that in real life practice what I try to approach is I usually do a combination of where my client's at. So obviously what's her health history, what is this her first birth, does she have an epidural, plays a big role. So if it's unmedicated, usually some more gentle approach would be okay versus if it's like her first also. I definitely cue in between contractions. I feel like that's where we have a lot more control. And so there I'll coach pelvic floor relaxation. And then when the contraction comes, she will then do a full mighty push.
Yeah, exactly.
So, and also depends if the baby needs to get out soon too.
Yeah.
So you'll hear the midwife or the doctor say, okay, let's do some good ones. And then versus when the baby's right in the canal, you might not push at all. It'd be dangerous to push and you might just do some panting, but the care provider will be teaching all of this. I mean, I'm going to teach it in prenatal and I'll say some cues during labor and birth, but at the end of the day, like I have to, as a doula, know where my scope of practice is and let the professionals deal with it. So I think that's why it's good to go see a physio before, so you have like a baseline, because you can't bring your physio to your birth. That'd be great. I think you guys should rock it there, but
yeah, no, for sure. And I think that that's where that building that connection with your pelvic floor ahead of time is really, really helpful. And people will ask, like, if I have an epidural, yeah, that will change things a bit in terms of like the sensations and what you're feeling and all of that. But you still have that mind-body connection in terms of at least being able to imagine what's happening or where the pressure is being directed or things around the pelvic floor. And then the other thing is that when we're thinking about pushing, so usually what I'll say to people as well is that, like, when you're actually at the point where you're pushing, there will be other people there. So the labor and delivery nurse or your maternity provider, your doula, and everyone's sort of there to support and assess how pushing is going. And if things are progressing and that's great, then you can kind of keep doing what you're doing. Totally. And if things aren't progressing well, then we might just need to change position or technique in terms of pushing. And so just being,
totally,
knowing different options.
Okay. Yeah, that makes total sense. And I think that at the end of the day, my takeaway is probably that it's important to book in just so that you can assess your pelvic floor and see where it's at, if it's hypertonic, lower tonic, and get a better baseline. So if you have benefits, like, don't hesitate. I understand that it's not always accessible for everybody, but even just going on YouTube and learning how to relax your pelvic floor would be like a good start, because I find that nowadays people probably are more hypertonic than anything from what I gather.
Yeah, I mean, it depends. And I think that, I know it's really challenging, and it would be ideal if, physio was more publicly funded versus just through Extended Health. So it's more accessible, but yeah, I mean, you can certainly go on YouTube or like try to gather information that way. We do know though that the best way and what's actually research supported is by actually seeing somebody, because
Totally.
It's, like I said earlier, this is an area that we're not used to connecting with. And so we do know that if somebody's sort of given like instructions but not actually having an assessment, then they're not actually benefiting from that necessarily.
Okay. Well,
so
that's good to know.
I know, but I know it's tough because it can be not as accessible either. So it's a bit challenging.
Well, as a doula, if you're one of my clients, I will try my best
Yeah.
to teach you what I can. To wrap up today, I just wanted maybe for you to just like share how people could find you, and if they were going to book in, like, how would they go about that?
Yeah, for sure. So I practice out of Victoria, and I am at 3 different locations. But you can find me at Uplift Physio. So upliftphysio.com. And that has all of my information and how to book with me at any of those locations. So I see clients one-on-one, and then I also do a group class that talks about birth prep and postpartum rehabilitation from a pelvic floor standpoint. So I always say that it's supposed to be supplemental to a traditional like prenatal education, because we're not talking about everything in terms of what to expect with labor and delivery, but it's more from the pelvic floor standpoint and rehab in postpartum, so that you know what to expect before you enter postpartum.
I love it. I think now that times are changing, people are having more of a healthcare team. Mm-hmm. So they have the doula and they have the massage therapist. People are using their benefits more so for labor and delivery, because the healthcare system is strained and flawed. And so having continuity of care and having like a badass group of women supporting you through birth and having a pelvic floor physio is major. I think that if you have accessibility, I highly recommend it.
Well, and I always highly recommend doulas,
because
yes. It's one of the first questions I ask: who's on your birth team, and do you have a doula, and do you know what a doula is? Because I feel like a lot of people don't always understand the doula's role, but there's a lot of research to support doulas. Support can be beneficial in terms of supporting a spontaneous vaginal delivery and helping to do manage pain and all of that. Mm-hmm. So it's really important.
It reduces like interventions by 30%, which is actually data and studied. And if your care team are on the same page as the doula, it's by 50%.
Oh, amazing.
Which is major.
Yeah, for sure.
But anyways, thank you so much for sharing all your information. You interviewed like perfectly and barely said any ums or ahs. Like, you definitely should share more. That was really lovely, and I learned a lot, and I know there's probably still lots more questions, and if there's anything that arises, do send me a message or send Nicole a message, and I'm sure she would love to chat more and support you along your pregnancy and postpartum journey.
Yeah, love talking about pelvic health. No, I was just gonna say thank you for having me. This was fun.
Yay!